Thank you. So thanks for inviting us to present, and I'm co-presenting with the manager of the clinic I work at, Patrick Daigle. Hi, Patrick.
Hello.
So I will try to share here. Okay, can everyone see this?
Yes.
Yes.
Great. Okay. Let me try to do this. Good. Okay, so Patrick and I work in Nova Scotia, which is the east coast of Canada. And we both work in the Nova Scotia Operational Stress Injury Clinic. And I also am a full professor at Dalhousie University in both the Faculty of Medicine and the Faculty of Health, Occupational Therapy, specifically. What we'd like to do is, and I'll give you an outline here in this next slide of what we're going to present today, is we'll tell you a bit about the background of the work we do. So what is an operational stress injury, and how is that working out in Canada in the national network? And then we'll describe specifically our service and its details. And then we'll talk about the focus of the presentation today, which is providing remote mental health care and how we shifted very much to it during the pandemic, and some of the challenges relating to this shift to remote care. But I will also highlight the strengths and give you some data about that. We'll conclude and give you some reference. So what is an operational stress injury, or what we call in short an OSI? This is not an official psychiatric diagnosis, not in DSM-5, which is the American classification in psychiatry, nor in ICD, which is the World Health Organization classification for mental health challenges. It is used to define any persistent psychological or mental health difficulty resulting from military and or police service of people who work in the military or police or worked there. It includes diagnoses such as post-traumatic stress disorders, depressive disorders, anxiety disorders, substance use disorders, and other conditions of varying severities that interfere with daily functioning, as well as some physical comorbidities, so physical conditions that often come with these mental disorders, particularly chronic physical pain that often is comorbid with these mental disorders. So I'll hand it over to Patrick for the next few slides to describe the network and the clinic.
Thanks, Remy. So our clinic is part of a national network. There's 10 different clinics across the country of Canada, and each are connected to provide services as outlined by Dr. Rudnick, the veteran community, those who served in the military, and the RCMP veterans and active members. The different locations are listed on this slide, the different provinces of Canada. We also have a residential treatment program located at one of the hospitals in the center of our country in Montreal, Quebec. And the OSI National Network provides guidance to our clinics. So not only are we located in our province of Nova Scotia, but we are also connected nationally with each of the clinics as well. Next slide, please. So individuals who are eligible at our clinic, so military veterans, the Canadian Armed Forces active members, and RCMP, our police service in Nova Scotia, as well as family members of each. Next slide. So we are a specialized outpatient mental health program. We are designed to treat the unique needs of each of those populations with their operational stress injuries. We provide eligible clients with comprehensive assessments and interventions, as well as recommendations and referrals. Our interventions may include individual psychotherapies, group education and therapies, pharmacological therapies, and occupational therapy, and people can take more than one of those at a time in our interdisciplinary clinic. We do not provide urgent care, but we do support our clients in getting connected to that urgent care. So we are a full interdisciplinary team. So those who moved virtually during this pandemic included nursing, occupational therapy and primary care, psychiatry, psychology, and social workers. Each of our clients at the clinic have individualized care plans, and clients may have more than one professional involved in their care at a time. We have a collaborative approach within the Nova Scotia Operational Stress Injury Clinic and with our community partners. Clients may receive more than one mode of care at a time. So for example, as mentioned, they could be in individual care, but also attending a group and, for example, seeing a family doctor or one of our psychiatrist team members as well. Remy, did you want to take this one?
Sure. So we provide standardized outcome monitoring using well-published outcome measures. And so we monitor outcomes of all clients in care, and they complete questionnaires, mostly self-report questionnaires, which are very common in mental health care, using an online system called Chromis that the national network has put in place. And this is used both for clinical care and monitoring individually. It's also used on an aggregate level, de-identified from the patient information in order to report to the national network and to make some policy decisions eventually on a national level based on that. This helps alert clinicians to change in the well-being and in functioning of the clients, and provides feedback to clients and opportunities for clinicians and clients to review this, and not just numerically, because these are scales with different numbers attached to them, but even visually over time, we can show the digital graphs to the client and show them how are they doing over time in treatment. So for remote care services, we do provide some that, so both by phone and secure video platforms. So the video platforms are at least three. One is called telehealth, and telehealth has been in place in Canada for a long while. It actually started in places like Australia with very large distances, but Canada has been an early adopter for decades now. And it's based on video equipment that is located in different clinical settings. The challenge with that is that it can only be done in clinical settings. And so if a patient wants to do it from home, they cannot do telehealth. And that's where software platforms like Medio and more now Zoom, but specifically Zoom for healthcare, which is a specialized type of Zoom, can help do it in a more flexible way from many other locations. And so the Medio Zoom platforms use smartphones, iPads, computers in the home and in office. And it helps reach clients who live in remote areas. And as you may know, Canada has the second largest land mass in the world after Russia. And so many clients do live at least a few hours drive away from a clinic, and therefore this access through video is quite helpful, even unrelated to the current pandemic. And some patients, even if they live closer to a clinic, don't want to do the drive every time they come to the clinic, so they can stay in their community and access care through the video services. And it also allows providing care from office to home, or even home of the provider to home of the patient when there are safety issues, such as during the current pandemic. And so the remote care delivery, let's give you a bit of the background context. We know from the literature, from the scientific literature, that remotely delivered mental health care and related services, such as self-help to remote services, is effective. There's research on that for nearly a decade now, and it's even also cost effective in some circumstances. So not only does it help patients clinically, in some circumstances, it can actually reduce the cost of service, or at the very least, not be more expensive than doing the things in person. The reference there in the first bullet by O'Reilly et al. Is from a group that I worked with in Ontario before I moved to Nova Scotia. And they showed that there is actually a threshold of distance, that these services are particularly low cost compared to regular services if they are done at a distance of 100 kilometers or more between the service provider and the service user. But unfortunately, in spite of all this evidence, until the current pandemic, most countries were not major adopters of remotely delivered mental health care through these technologies. So it has been hit and miss and pockets of this service, but not full adoption in Canada or even in Australia, UK, US, Europe, Asia, and other places, countries and continents. Partly, the reason quoted in the literature is that in order to go large with these services, there is a startup cost, both in money, in time, in training of clinicians, and changing a bit of the culture of practice, including with patients and their families. So that was a bit prohibitive, and many services were reluctant to go broad to remote mental health care until the current pandemic. And within our own clinic, the Nova Scotia Operational Stress Injury Clinic, the NSOSIC, until the current pandemic, meaning until early 2020, the virtual care platforms were used sparingly. So it was used, but not much. On average, 5% or less.
就是谁呀？直传。
I can hear someone in the
Yeah.
background.
Yeah, sorry. So that is from Julian, Professor Julian. So yeah, Professor, you can continue now.
Okay,
Yeah.
so I just repeat that last point. So until the current pandemic, these virtual care platforms at our clinic were used, but not much, sparingly. So on average, 5% or less of all of our clinical appointments were on video care. And mostly they were used for patients who lived in remote areas, so quite far, at least a few hours drive from our clinic. So without this video care, they wouldn't be able to easily access our services. And so the ongoing virtual care implementation challenges were particularly related to the level of comfort of the patients, but also of the staff, and particularly the psychotherapists, who do intensive work. And so when we work with someone with post-traumatic stress disorder, sometimes during the session, the appointment, the patient may get worse as part of the treatment. For example, typically in post-traumatic stress disorder, people have what we call dissociative symptoms. So they may be spacing out, they may be disconnecting from current reality, and if they're treated in person, therapists can help them face to face and even sometimes touch them to help them do what we call grounding, so to bring them back to the here and now reality, whereas doing it with video may be considered more challenging, and that was some of the reluctance, the concern of some of our staff before the pandemic to do more of this work by video and not in person. So maybe Patrick, over to you for the next slide.
So in March of 2020 is when we really started to see some of the significant COVID-19 cases in Nova Scotia. This was also a time where Nova Scotia, for all intents and purposes, began to shut down. So all elective outpatient mental health services are being asked to reduce in-person appointments and utilize remote platforms as much as possible. Most clinical staff shifted to remote at-home work. is a preferential basis. And the Nova Scotia Health Authority IT software and hardware used to facilitate secure connection to the clients and to the Nova Scotia Health Authority health records. Clinical forms all converted to digital forms, with the Nova Scotia Health Authority approving electronic signatures. These were some vital changes that occurred because these were when folks were at home, the small pieces that would force them to come to the office. So in the early stages, we shut down for 3 days. We didn't see clients for 3 days in late March, where we regrouped and we worked as a team to implement things quite quickly. And then we slowly began seeing clients over the next course of a couple of weeks and using virtual care. So within those weeks of the pandemic onset, care had moved almost exclusively to remote care platforms. Communication, education, and culture shift facilitated by the Nova Scotia Operational Stress Injury Clinic leadership to advance this change was vital, to work closely with the team. And there was some kind of exceptions. Any care that required physical examinations were completed in person using the protocols approved by our health authority, and group-based interventions were canceled and reintroduced virtually in September of 2020, and they are still virtually now. So Medeo and Zoom for Healthcare are two of the platforms, as Dr. Rudnick had discussed earlier. Clients can connect via video conference from home using from range of devices, so computers, tablets, and smartphones, and client clinicians' preference taken into account. So some have reported the compatibility issues using certain platforms with their devices, and we try to work with what platform works best for them. Phone-based appointments used when the client did not have a compatibility device or technology difficulties arose. So we always had a backup plan in place where we had the client's phone number, and then if technology for some reason or other failed, or there was remote access issues, which can happen in Nova Scotia in some parts and pockets, then we would call them to ensure that we were able to accommodate and finish their session via phone. Appointments durations varied based on care plans as well. So there was an opportunity for an internal quality improvement project in all of this. So we took the different appointment types, so telehealth versus phone versus in-person, the appointments completed as planned versus appointments that were unexpectedly where challenges occurred, and the staff comments about the challenges they encountered. And then we took that data and we collected on a weekly basis. So a form was created for each of the clinicians based on each of the sessions they had to provide data that would allow us to recognize the challenges they faced with the clients that they serve, or the technical challenge. In addition, also the challenges to the protocol treatments that they were doing. And then we tracked that on a weekly basis over time. All data was based on the clinician's reports. Not all clinicians submitted data for the QI project on a weekly basis, so there was limited interpretations. Remy, do you want to take care?
Sure. So we'll show you two graphs with our data here. The first graph on the slide here is about appointment types that occurred over those 13 weeks from early May to late July, which are those 13 weeks where we quickly ramped up into the shift to pandemic mode of care for our services. So as you can see, first week, which is early May, there was nearly no in-person care. It was nearly all remote video or phone. And then you see fluctuations, and gradually starting week 6 and eventually a bit more over the weeks, there's more in-person care, partly because Nova Scotia for the last few months has been fairly stable with the pandemic. There are nearly no new infections. There are no new deaths in the last few months. And there are very few, if any, people in the ICU. Nova Scotia is a province of nearly 1 million people. So we've been pretty stable and well contained with the pandemic, fortunately for us. And so gradually there has been a bit more in-person care. But if you look at this graph, you'll see that still, even at week 13, which is late July, most patients and staff prefer to engage in care remotely and not in person. The black dots are the number of clinicians reporting this. There was a dip down at week 8. I don't exactly remember why, but overall most clinicians did report during this period. And as you can see, video was used more than phone. That's partly because we do encourage it more than phone, because there's more opportunity to provide full care when there's visual contact in our type of service in mental health care. And now if you look at the next graph, this is tracking how much care deviated from the plan, largely because of using this remote type of delivery. And so you can see in week 1, early May, that although most care, green, did not deviate, but more than 20% actually deviated from the planned care. And that is partly because of technology glitches, partly because both some of the clinicians and some of the patients were not used to this modality. And over time, as you see, as time goes by the end of the period, week 13, late July, less than 10% of the care deviated from the planned care. So we consider that a success, that within a very few months, we can provide the service as planned, unrelated to whether it's in person or by video, or even sometimes by phone, rarely by phone. And so what are some of the challenges with shifting to such remote care? Initially, for the first few weeks, we had a decrease in referrals of new patients after the onset of the pandemic. Very obvious why. People were more focused, both the patients, the staff, and also the referral sources, Veterans Affairs Canada and the Royal Canadian Mounted Police Health Services. They were focused on the acute situation. But after a few weeks, that problem resolved, and we are now, and have been getting for a few months now, are getting at least as many referrals as we were getting before the pandemic on a monthly basis. So another challenge that Patrick mentioned was the internet connectivity issues with some clients in some rural remote areas. Unfortunately, in Canada, we still don't have full coverage of wideband across all of Canada. In Northern Canada, it's more spotty, and occasionally in some rural areas in Nova Scotia too. The majority of our clients have no problem, but some do. And then another concern is few clients don't feel comfortable enough receiving remote care and prefer in person. Anecdotally, without being able to collect good data on that yet, it seems to me it's the older patients who feel a bit less comfortable with that, but most patients are comfortable with this service delivery. And initially, as I mentioned, some clinicians were not that comfortable delivering remote care, but now pretty much everyone is on board and are very comfortable in delivering remote care. And then there was an unfortunate incidental event unrelated to the pandemic in April 2020, where there was a mass shooting of more than 20 people killed in Nova Scotia by a person who died during that, but masqueraded as a police officer. And so you can imagine for our clients who are police officers, or some of them were police officers, this was particularly stressful because for the first few weeks, there was this perception that the public did not trust police officers anymore. They didn't know who's a true police person, who is not. That has reduced in problematic presentation, but for the first few weeks in April and May, it was another stressor added to the mix of our client population.
If I can just quickly add, another complicating factor with the mass shooting in Nova Scotia, which is a credit to our team, is that our team took on a lead role in the response to the mass shooting in Nova Scotia in a virtual way as well, strengthening their comfortability with virtual care as we moved into providing 24-hour support for first responders in the province. So there was an increase in the number of people they were seeing, which helped them get more comfortable using the virtual platforms also. Thanks, Remy.
And this is in parallel to addressing the pandemic and making sure that all our clients who want and need service receive service. So this is life. Things get more complex than expected. So in conclusion, evidence-based mental health assessment and care delivered remotely can be effective and likely cost-effective, as shown in published research. And the shift to remote care can happen quickly with little deviation from planned care, as we show in our quality improvement project with the data we presented to you today. And both in and beyond pandemic-related circumstances, remotely delivered care can be helpful. For example, for those patients with mental health challenges who live in rural and remote areas, if technology such as broadband is accessible, which it should be, and there's ethics and other literature, such as human rights literature, mine and others, arguing that internet access these days should be considered a basic human right, because education, work, healthcare, and other things can be more accessible that way. But well-controlled research is still needed to address processes, outcomes, and their predictors in relation to shifting to remotely delivered mental health care. These are some of the references, and I'll highlight the second one, Patrick and mine, that was published this year in an open access journal, Psychiatry International, where we present these data. So they're rapidly doing the QI project was joined also with rapidly publishing about that, so that other services can learn from that. And with that, we end the presentation and open it up for questions and comments.
Thank you, Professor. It was a wonderful and great presentation. And regarding our current situation, and especially the COVID-19 situation, so we all do believe that it's a very big challenge that we have to shift to the online platform. So it's a kind of same feeling or emotion that we are now doing events like this, like through Zoom meeting or online events. So that I can relate to it, and it was a nice presentation. And I'll leave some time here for other professors. If anyone have any comments or questions or anything you wanted to ask Professor and to our panel, you can ask.